Good afternoon. So good to be here. Thank you for the opportunity to present on a timely subject in the Pediatric Echo Forum. I'm a pediatric sports medicine provider at the Kapiolani Bone and Joint Center, along with my colleagues, Dr. Jennifer King and Dr. Rachel Cole. We also staff the multidisciplinary concussion clinic at Kapiolani. I'm here to discuss the best practices for concussion prevention, assessment, and management, primarily with a focus on the changes highlighted within the Amsterdam Consensus Statement for Concussion, which was just published a few short months ago. I have no financial disclosures. Plan for today. First, we'll talk about the origins of the consensus statement for concussion in sport, who was involved and how it came to be. We'll then discuss the key points from the consensus statement, highlighting especially the changes from previous statements. Anything that is in italics font is essentially verbatim from their key points portion of the publications. Next, we'll discuss the proposed tools for concussion assessment from the sideline perspective to the in-office perspective. And this dovetails into the return to learn and new return to sport guidelines, which were published. Finally, we'll talk about promoting recovery, both in the expected recovery interval and the protracted recovery interval beyond 4 weeks, based off the predominant symptoms exhibited by the athlete. Before I jump directly into the nitty gritty, this is my pediatric street cred. Ellie is now 7, Cameron is 3.5. This picture was taken at an event called Touch a Truck Day in Southern California. There were fire trucks, dump trucks, bulldozers, excavators, and a cherry picker that they were dropping water balloons from 2 stories onto the waiting kids below. No concussions while I was watching, but there were a few close calls. All right. So the 6th International Conference on Concussion in Sport was held in Amsterdam in 2022. And it was a culmination of a 5-year process resulting in the development of the new statement. The naming convention for each of the preceding conferences includes the year and the city in which the conference took place, hence Amsterdam being in the title. Those in attendance were members of the Concussion in Sports group, which is a multidisciplinary international group of, in this year, 30 individuals who are reviewing thousands of articles and 10 systemic reviews on priority topics relevant to concussion in sport that were conducted over the last 5 years. This, of course, as you probably already gathered, was not the Concussion in Sport Group's first rodeo. This was the 6th international meeting of this type since 2001, rather. While human beings have been injuring their brains since time immemorial, you wouldn't be wrong to say that modern concussions were invented in the form of their definition in the 2001 manuscript. Since then, the conceptual understanding of concussion has been updated, built up based on the most up-to-date studies available. The previous conference in concussion was in Berlin in 2016. There had been a planned session in Paris, but that was canceled, as you would probably expect based on the timing. So this consensus statement process took 2 years longer than initially planned due to the pandemic-related postponements. And as a result, they aim to be more extensive than previous versions. The Amsterdam Consensus Statement summarizes the state of the science, incorporates evidence-based practice with several novel aspects in prevention, assessment, and treatment in mild TBI. It should be noted that there was a renewed effort towards transparency in their methods and voting outcomes for their specific various recommendations. The conference's outcomes were intended to serve as summaries of TBI-related evidence at the time of the Amsterdam conference, and to inform us as healthcare practitioners and sports organizers in the interest of improving athlete care in all levels of sport when it comes to TBI. The outcomes from this meeting were documented in the June issue of the British Journal, of Sports Medicine. What was included in this issue was not just the position statement, but also access to the various new concussion assessment tools, systemic reviews, and several of those tools, and also detailed information on the methodology and research behind the recommendations provided. And what's more, they actually made those resources free, which is rare these days. So no paywalls for the vast majority of it. I highly recommend at least reading the statement itself. Also, the tools that were recommended for post-concussion serial assessments, which we will discuss today, are also free and available to be printed from PDF format if desired. If you're watching this recorded in the future, just go ahead and open another window now so you can have the articles pulled up for future reference. If you're watching live, you may want to just go ahead and grab a screen cap so you can track these down. It's also the top hit on Google right now with just a simple search of British Journal of Sports Medicine, Amsterdam. So I simply do not want to go any further and bury the lead any longer here. So I'm going to go a bit out of order in terms of the natural flow of the way that they recommended things, and cut directly to the single thing I really hope all healthcare providers watching take home from this presentation. Strong evidence exists regarding the benefits of early physical activity and aerobic exercise as our early interventions. This goes beyond simply saying return to normal activity. No, post-concussion, we should think about doses of non-sport related physical activity as treatment to reduce morbidity from brain injury. Now, this is by no means brand new information. John Letty in 2018 published his landmark research into the Buffalo treadmill test. And for those of you who have never heard of this protocol, disappointingly, it does not actually require use of any actual buffalo. But it is a good protocol for using a simple treadmill that provided a framework in which athletes could gradually and safely return to physical activity within guidelines for personal symptom exacerbation. For the autonomic nervous system, it turns out that exercise is medicine after a concussion. But this is significantly different than the information provided in the previous consensus statement in 2016, when they advocated for full symptom resolution before any physical activity was to be attempted. So it is now standard of care, and PCPs should not be afraid to start simple cardiovascular activity very early in the process. This can occur concurrently with the return to life and return to learning in school phases. This is even okay if the patient is mildly symptomatic. The rule of twos that's being referenced here is that in terms of headache severity on a 10-point scale, we encourage activity until the symptom severity goes up by 2 points from their starting baseline. Please note that this is prior to and separate from the return to sports strategy for contact athletics that we'll talk about later. Now, the opposite is also true, as it turns out. Prolonged rest is correlated with prolonged symptoms. There are several factors involved: physical deconditioning of the body, metabolic disturbances within the brain and the bloodstream, fatigue from disruption of your normal routine, and the resultant mood changes from the depression and anxiety. So again, strong evidence exists for the early interventions of physical activity and aerobic exercise. And there's no evidence that rest beyond several days is beneficial in the overall recovery process or in terms of preventing post-concussion syndrome. So back to the proper order of the key updates. Let's start with some definitions. So concussion remains a clinical diagnosis. Concussion is a mild traumatic brain injury. Mild TBI and concussion are interchangeable terms. So as this is a clinical diagnosis within the new position statement, they state that kind of within a wall of text. The American Congress of Rehab Medicine diagnostic criteria, which was published in May of this year, actually provides a flow chart. It's a little easier on the slides. So let's get into the nitty-gritty for a couple of minutes to define what it takes to make the clinical diagnosis. According to the American Academy of Rehabilitation Medicine, you must have a suggestive mechanism first, and this includes a transfer of mechanical energy into the brain from external forces, either by the head being struck by an object, the head striking the object or surface, or the brain undergoing acceleration, deceleration movement without direct contact between the head or a surface, or forces generated from a blast or explosion. Once that mechanism is ascertained, we can move on to the clinical signs. If any of the following are present: 1, loss of consciousness; 2, altered mental status; 3, anterograde or retrograde amnesia; or 4, post-injury acute neurological signs such as a frank seizure or tonic posturing, or observed motor discoordination with them standing and walking, you already have enough to make your diagnoses of mild TBI, as long as any of these are present and cannot be accounted for, as you can see there in box 6, by any other factors. So if they're having difficulty ambulating, but they actually have a sprained ankle, then that's not a TBI. But if you don't otherwise have something to explain it, then you already have your mild TBI diagnosis. Alternatively, the diagnosis can be made with a suggestive mechanism and reported acute symptoms on the part of the patient, and with a clinical finding on your exam. So those patient-reported acute symptoms include: 1, a subjective mental status change; 2, physical symptoms such as headache, nausea, vision changes, balance, light or sound sensitivity; 3, cognitive symptoms, including feeling slowed or having brain fog; or 4, having emotional symptoms such as lability or irritability. 2 of those 4 is necessary, along with a clinical exam indication of cognitive impairment, balance impairment, or oculomotor impairment. It should be noted that neuroimaging is not considered standard in the assessment of a mild traumatic brain injury or concussion, but if a CT or an MRI were to be completed and found unambiguous intracranial anomalies, such as a hemorrhage or an axonal shear injury, that is also immediately diagnostic of at least a mild TBI. If the patient doesn't quite meet the acute symptoms and the physical findings, there is also a physical findings criteria for additional indications when to label the event a suspected mild TBI. Additionally, it should be noted that if the TBI is no longer considered mild, if your loss of consciousness exceeded 30 minutes, or if your Glasgow coma scale was 12 or less after 30 minutes, or if your post-traumatic amnesia was exceeding a full day, 24 hours. So in short, your clinical diagnosis is achieved with a suggestive mechanism, 1 or more clinical signs witnessed that are attributable to brain injury, or 2 acute symptoms reported with 1 clinical exam finding or laboratory finding when you assess them without any confounding factors. So what's better than successfully defining and treating a concussion? Preventing a concussion. So over the last 5 years, there's been a 3-fold increase in the studies examining the effectiveness in sports-related concussion prevention. They've assessed policy and rule changes, personal protective equipment, changes to training strategies, and overall management. So studies including children and adolescents actually represented over 60% of the studies evaluating sport-related concussion prevention strategies. So let's talk about some of the findings that were highlighted. First of all, mouth guards were associated with a 28% reduced concussion rate in ice hockey across all age groups. The policy that disallowed body checking in the child and adolescent ice hockey arenas reduced the rate of concussion in games by 58% and did not seem to cause an increase in concussions later when they started body checking compared to what it was like before. Policy and rule changes limiting the number and duration of contact practices, contact in practices, and strategies in restricting collision time in practices for American football across all age groups led to an overall 64% reduction in practice-related concussions and reduced head impact rates. Participation in on-field neuromuscular training, or NMT warm-up programs, as long as they were completed at least 3 times a week, were associated with a lower rate of concussion in rugby across all age groups, actually. There were a couple of notable omissions. The evaluation of headgear in non-helmeted contact and collision sports like soccer, they did speak on, and they said it requires more research to inform headgear recommendations. Specific recommendations for helmeted sports were also not included in terms of helmet choice, although it should be noted that Virginia Tech does have their yearly helmet scores in terms of how much they can reduce impact, reduce skull fractures and brain bleeds, and that is easily available, and you can find that online. They also did not talk about the Q collar, which was an interesting device that was approved by the FDA within the last year that limits jugular venous drainage by putting direct pressure around the neck in an effort to reduce intracranial brain motion with impact, usually in soccer players. They did not have suggestions for these interventions based on their current literature review. So new tools for the assessment of concussions were also made available. It's kind of an alphabet soup of terms, so I'll seek to disambiguate where I can here. The CRT is the concussion recognition tool. This is the most simplistic tool, and it's designed for non-medical trained individuals, perhaps a coach to utilize on the sideline. Next step up is the SCAT. The SCAT stands for Sport Concussion Assessment Tool. And it's intended for medically trained individuals, usually within 72 hours, but it's been validated for use up to 1 week. A child version was added this year for patients 12 years of age and younger. And finally, there's the SCOAT, S-C-O-A-T, and this is the Sport Concussion Office Assessment Tool. This is to establish the diagnosis or predict the prognosis of concussion and affect clinical impairment and function in the patient in the subacute phase of injury, usually between 3 and 30 days. There's also a child version of this tool. So what do these tools have in common, besides unfortunately sounding very similar when you say them out loud? They're all multimodal tools for concussion assessment, and components of these tools are going to assess with your clinical assessment and hopefully guide individualized management for the person directly in front of you, ranging from on-field assessment to directly off-field, possibly in the training room, all the way to serial follow-ups within the office environment. The acute phase within maybe the training room environment, the modal tools and the multimodal is making up generally consist of observable signs, a quick symptom evaluation via graded symptom score, cognition over memory, recall and concentration, as well as coordination and balance. Finally, when you're in the office phase, those multimodal tools are going to also, in terms, also gather more history in terms of their previous history of concussions, learning disorders, other pre-existing psychologic conditions, also incorporating pretty much everything that was seen in the acute phases, but also with orthostatic vital signs, cervical spinal assessment, neurologic evaluation, balance assessments, and screening for anxiety, depression, and sleep. We'll review those a little bit further. It's always good to have new tools in the toolbox, but it is important to know what these tools look like before you utilize them for your individual practice. For some, using these directly out of the box may be adequate right off of the PDF, but for others, you may need to augment your delivery in order to use them efficiently and effectively in a high volume clinical setting. So let's take a quick look at some of the elements from these tools. First, there was a previous version of the SCAT that was pre-existing, the SCAT 5, since 2016. So let's talk about what some of the updates are for that from that particular range. For those of you who are covering athletics on the sideline or simply in their child's games, this may be helpful. Their stated goal was to add a more robust set of visible signs to the assessment tools. These included falling with no protective action, tonic posturing after the fall, an impact seizure, ataxia or motor incoordination, altered mental status, or a blank, vacant, or dazed look. If any of those findings are present, that should allow for a more efficient removal of the athlete from play, and completing the full SCAT, the sideline assessment tool in that moment, is not necessary to make the determination of concussion or not concussion at the time of injury. Likewise, if there are red flag findings present, and this includes neck pain, cervical tenderness, especially in the midline, obvious seizure or convulsion, persistent double vision, loss of consciousness, weakness or tingling in more than one arm or in the legs, deteriorating conscious state after the injury, they start vomiting, they're having an increasing headache even after they've rested, if they're becoming increasingly agitated, combative, or if their Glasgow Coma scale is less than 15, and certainly if they've got a deformity of their skull, these are signs that immediate medical assessment may be necessary, and they may require medical transport from the facility at which they were injured, as this may be more than simply a mild traumatic brain injury in those cases. So this is the flow chart to determine if utilizing the SCAT-6 is recommended for your injured individual, or simply removing them from play and considering additional medical assessment away from the sideline would be more appropriate because of just how obvious your traumatic brain injury diagnosis already is. They start with the red flags we already went over, and if you've got those, you do not pass go, do not collect $200, immediately remove, immediately send them for additional assessment if you can't keep direct eyes on them. If you don't have those, but they've got those observable signs we talked about before, additionally, you may want to consider removing them and assessing them further yourself, or sending them for additional management. Glasgow Coma scale decreased. Again, that's an immediate departure away from additional assessment at that point. If they've got neck pain, tenderness, and a loss of range of motion, potentially getting them into spinal immobilization, spine board, or a cervical collar before assessing them further would be a good idea. Additionally, if they need to pass your ocular motor screening, and then simple memory questions. And if you get down to all of those, it may not be immediately obvious if this represents a concussion, as it doesn't necessarily meet those criteria we talked about for our clinical diagnoses. And so continuing with administration of the SCAT-6 may be extremely helpful to further determine if this does meet criteria and what to do next. So the sport concussion assessment tool is then designed to be continued in the post-sideline athletic training room, or later in the office environment on the acute interval after the concussion has occurred. The SCAT-6 is an easily deployable multimodal tool used in the acute evaluation by healthcare professionals. But again, importantly, this remains a clinical endeavor. So your information from the SCAT-6 is just one part of your overall diagnostic process. If you haven't seen this before, I have some examples of the tests on the upcoming pages, but here are the changes from the SCAT-5 if you were familiar with those already. In addition to the visible signs we talked about before, they improved the psychometric properties with a longer word list. So we use 10 words of memory instead of 5 to reduce the learning effect. They added digits to the digit span backward subtest, which they increased the longest string by 2 digits up to 6. We'll see that here in a second. They revised the months backward test with the addition of the component of timed information processing, and they added timed dual gate tasks as an optional task as well. So here's some examples from the SCAT-6 reflecting those changes. Within the cognition memory stages, these are the memory word lists that were suggested. You say, I'm going to test your memory. I will read you a list of words, and when I'm done, repeat back as many of the words as you can remember in any order. This used to be, again, 5 words, and they kept the original 5 words that I'd committed to memory long ago, over half a decade ago: elbow, apple, carpet, saddle, bubble as the alternate. Let's see final 5 words in there. You do that in total of 3 times, taking note of their score. And then after you do all the additional tests we talk about for a delayed memory, there's also a delayed recall score that you have with that. Next, within concentration testing, we have the months in reverse, the digits backward test next here overall. You say, I'm going to read you a string of numbers, and when I'm done, I want you to repeat them back to me in reverse order of how I read them to you. So if I say 719, you say 917, then you confirm that they understand exactly what you mean by that. And then you start to go up as you go down these lists by 1 digit each time. They're allowed to make 1 mistake, and once they make their second mistake, that's where you stop overall, and they're scored at that point. Next, within the concentration testing is the months in reverse order. You say, tell me the months of the year in reverse order as quickly and accurately as possible, starting with the last month and going backward. So you'll say December, November, go ahead. And this time around, there's also a timed component that goes into their scoring. Moving on to coordination and balance. The best test for balance has not significantly changed. It wasn't, as of the last time this was updated, considered to be as useful as previous tests after the 72-hour window, but it was revalidated as a measure of recovery in that subacute test within this last statement. So it is back. If they're getting past the best effectively, you can then move on to a tandem gait where you have them walk heel to toe quickly to the end of a tape, turn around and come back as fast as they can without separating their feet along a 3-meter long line. And there's scoring criteria for that. If they're able to get through that without too much difficulty, you can make this trickier with the tandem gait, the dual task tandem gait, that is. So you say, while you're walking heel to toe, I want you to count backwards out loud from 7. So example, we started at 100, you say 100, 93, 86, 79, and you make sure that they know what they're doing before you start the exam. As you can imagine, this is a little tricky to do, even when you're not recovering from a concussion. So it's good to practice in advance so you kind of know what to expect overall. Let's move on from those more acute tools into the SCOT-6. So as I previously mentioned, the SCOAT is the new sport concussion office assessment tools. And these will provide a multimodal clinical assessment tool to be used in serial evaluation of athletes in the post-concussive environment in the office. It stands on the shoulders of the SCAT, so it includes the tools we've seen on the previous slides. And apart from the diagnostic accuracy, the appropriateness of the tests for the office environment was considered, as well as accessibility, time to complete, as well as cost. It was designed to access in depth 12 different clinical domains, including global symptom scales, cognition, vestibular ocular, cervical spinal assessment, neurologic exam, autonomic dysfunction, balance and postural stability, sleep screening, depression screening, and then an exercise stress test. you are pediatricians, and it should be noted that there's limited evidence that exists that sport-related concussion in patients aged 5 through 12 years of age, which is unfortunate. So there are some tweaks for the child version, which include additional graded symptom score questions, and the cognitive tasks within the child scope are modified to age-specific tasks. So the memory begins with 2-digit strings of numbers. The days of the week are used in reverse order rather than the months. There's pediatric-specific vestibular assessments, as well as the updated orthostatic blood pressure normals and the pediatric versions of your behavioral health screenings. As an aside, I'm always up for a good challenge. And I attempted to utilize the child scope directly out of the box 2 days after this statement was published. And I'll be honest with you, it could have gone better on the first attempt. The scope document for reference is 15 pages long on the PDF. My pediatric patient wasn't particularly compliant with all the features of the exam. His grandma was with him. She was totally helping him cheat over my shoulder, especially on the memory sections. And I completed the testing dutifully, totaled up the numbers, and I didn't have an immediate, simple comparison to baseline that let me know what those numeric scores indicated for my patient in that moment that day. It was nice to have comparison scores to monitor during this patient's recovery, but it was time consuming, and there are potential pitfalls here. So my point is to familiarize yourself with these new tools, even if you already know the SCAT5, before you employ them into your clinical environment as part of your regular practice workflow. Return to learning. So academic support should address factors that may prolong your return to learning by adjusting your environmental, physical, and curricular and testing factors as needed. Not all individuals will require return to learning strategy or academic support after a concussion. But if significant symptom exacerbation is occurring during cognitive activity, with screen time, difficulties with reading, concentration, and memory, or other aspects of learning, then we should consider the implementation of a formal return to learning strategy. And this table was included within the consensus statement. A word of caution here as well. I do think there's some potential for misunderstanding here. This new table provides a framework for an individual with significant symptoms or a longer layoff from normal activities of daily life or school. This is a situation that we seek to avoid in the first place, but it may be reasonable in some cases. The concern I have is all the way down here at step 3, you've got placing return to school part-time all the way down there at step 3. And that creates some potentially problematic situations for some students. In particular, from talking to several neuropsychologists, they've expressed concern about extending the part-time school return, instead favoring keeping the patient in the school environment full-time despite mild symptoms in an effort to maximize their recovery overall. A few things to remember about return to learning from the Amsterdam statement. Your recovery is going to be variable. So we need the support to be flexible on the part of the school. And this is in their wheelhouse in terms of their return to learning. The return to learning generally takes 10 days on average, and higher initial symptoms need more academic support. Be aware that females and those with migraine histories on average need longer and slightly more intensive academic support, and return to learning should be completed fully before you return to contact sport, and that is going to be emphasized. So finally, back into the return to play side of things, including that early return to cardiovascular activity, the return to play protocol has been overhauled within the Amsterdam statement, but the previous return to play protocol is currently codified within Hawaii state law, and that's going to need to be updated, although it will not occur in time for the present football season. So you will still see the old version of everything on your current documentation for this year. Here's an excerpt from the existing laws. In 2012, Act 197 was passed, and then 2016, following the Berlin Statement, Act 262 was passed. It is mandated that there is concussion education for athletes, parents, and school sports officials, with annual update for coaches and athletic trainers here in Hawaii. Removal from athletic activity for a suspected concussion is mandatory, and medical professional assessment is required before return to play protocol can be initiated. As a medical professional, it's outstanding that you can be able to treat student athletes with the law backing you up. Although now we need the new update for the return to play protocol, as we will discuss, and of course the wheels of bureaucracy do turn slowly at times. So this may look familiar to some practitioners. To aid in communication, the Department of Education athletes have a defined form from the school athletic trainers that they can submit to physicians. This is the top half of that form, mostly with demographics and a description of what occurred. And then on the bottom half of the form, the medical professional can approve of the level of return to school and activity where appropriate. This is still the current form you're going to be seeing this year. The old version of the return to activity plan is on top with these 7 steps. You may know at this point, each separated by 24 hours before the next step. Please note that previously there was no physical activity even permitted until step 3, once return to learning was fully completed without any symptoms. I've been updating the bottom half of the indicated of the form with the indicated level of clearance with the suggestion toward early aerobic activity as tolerable, and then I signed that and returned to the school. I've had some luck with that here. So let's talk about that newly updated return to sport strategy. I really like this quite a bit. This slide is the first half of the new protocol. Second half's on the next slide here. As with the previous protocol, each step is designed to take 24 hours. So you'll notice that symptom limited light activity like walking is suggested within the first 24 hours post-injury in step 1. And this is at the same time during the return to learning. After 24 hours, the goal is to increase that heart rate. Aerobic exercise with 2 levels of difficulty at 55% of max heart rate and 70% of max heart rate, defined based on age, which is the number 220 minus the person's age as their maximum heart rate, and permitting mild and brief exacerbation of symptoms with that, again, that rule of 2 severity that we talked about from before. So again, if there's an increase in no more than 2 points on a 10-point scale when compared to their baseline value prior to their physical activity. Step 3 allows for self-directed sport-specific training without putting your head at risk while they're still away from the team. It's going to help to get some athletes engaged while they're still symptomatic and hopefully prevent them from putting themselves in a catastrophic situation. If more than a mild exacerbation occurs of the symptoms during these steps 1 through 3, then the athlete should stop and attempt to exercise the next day so we can determine if they can restart these again overall. Again, these are the first 3 steps that are going to be occurring away from the team after an injury. So steps 4 through 6 are only going to begin after the resolution of any symptoms, any abnormalities in cognitive function, or other clinical findings related to the current concussion. This includes both the physical exertion from steps 1 through 3 that should be completely asymptomatic at that point, as well as their return to learn being completed. So after that point, you can move on to steps 4, 5, and 6. So athletes experiencing, the final 3 steps then can be attempted within the team environment at that point. Step 4 with non-contact practice drills, step 5 with full contact practice, and finally step 6 with normal gameplay without any restrictions. Athletes experiencing concussion-related symptoms during the steps 4 through 6 should return all the way back to step 3. To establish that their full resolution of symptoms can occur at any level of exertion before engaging in at-risk activities. The written determination of readiness and the return to sport should be provided by a healthcare provider before the unrestricted return should be permitted. Overall, I think this is good. These changes make sense to me. That accounts for early aerobic activity and self-directed activity prior to returning to the team, which is going to be protective in this case, while simplifying the return to play time frame once they're back on the field in a way that's easy for a coaching staff to understand as well. I'm hopeful that we can adopt this and that it becomes easy to use over time. Emerging technology was also discussed in the consensus statement. There's a lot of very interesting and exciting new assessments being researched. It's an exciting time to be involved in concussion research. Advanced neuroimaging, fluid-based biomarkers, genetic testing to determine brain injury susceptibility are all showing promise. But at present, the authors concluded that these emerging technologies are only valuable research tools in the study of concussion and are not suited for routine use in our clinical practices. Furthermore, the use of neurocognitive tests that have years of use, baseline score comparisons, and name recognition, such as the impact or sway, are not to be used in isolation, but as pieces of our clinical picture to determine what's going to be best for the patients in front of us. For children or adolescents with headaches, neck pain, or dizziness or balance problems, At 10 days, we can start to think about physical therapy interventions. We've known about the importance of having these interventions, but we haven't had that time frame before. So it is really great that they were able to make this particular recommendation and give us that time frame. Again, if they're having these persistent symptoms that are either worsening or not getting better, 10 days is about the time to start considering either cervical therapies or vestibular rehabilitation strategies. Cervical stretching therapy is fairly straightforward. We're stretching the muscles around the neck to improve range of motion and symptomatic stiffness. But let's take a few minutes to look at examples of what vestibular ocular therapy looks like in practice, because that might not be totally as clear. So I've got a video, and it's a miracle. It's actually playing. That's good to see. So this is Kimi Aina, one of our physical therapists who is trained in vestibular ocular therapy, throwing a beanbag, which is being caught in a cup over there by our concussed athlete. This is a simple vestibular activity, eye-hand coordination with the use of cups to account for proprioception overall. Next, we've got a more advanced eye-hand coordination progression of vestibular exercises. The beanbags are being thrown on both sides of the fields of vision, and there's crossing over every now and then with more difficulty. Generally, Kimi does add dual tasking onto these as well. So when she throws them straight, the person will name an object that starts with the letter C, and when she crosses them over, they'll have to mention some kind of food that ends in hamburger. I'm just kidding. Some kind of a food or something else like that, or an animal that begins with the letter S. As a result of having those dual tasks, it gives you an idea of what they're actually able to do and gives you an idea of their cognition at the same time. Finally, here we go. This is the most challenging one so far. Beanbags are being thrown from the superior field of vision. There's testing not only just reaction and anticipation, but the vestibular symptoms are going to be most taxed with the patient being supine, laying down rather than standing up. This is the level of reactionary eye-hand coordination for an athlete that they may need to do over-the-shoulder catches as part of their sport, or more functionally for older adolescents, be able to head check to effectively drive a car. If you can't do these, I don't really want them getting behind the wheel around me. All right, delayed recovery consideration. So persisting symptoms, which some people have labeled post-concussion syndrome classically, are now defined as greater than 4 weeks across all age groups. These symptoms may be pre-existing, concussion related, or both, or a mixture of the two. Concussions tend to be a great magnifier of previous baseline things that you may have been exhibiting that were simply subclinical overall. Having a skilled practitioner earlier available in the recovery process has been shown to improve outcomes, having your PCP or an athletic trainer kind of quarterbacking what's going on. But at this stage in recovery, beyond the 4-week mark, referral to clinicians with specialized knowledge and skills in concussion management should be considered for the targeted treatment of those persisting symptoms for each patient. Common considerations in the context of persisting symptoms include mental health issues, learning or attention difficulties, visual, oculomotor, or cervical vestibular problems, headache disorders, migraines, sleep disturbances, or dysautonomia, including orthostatic intolerances. So if your multimodal clinical assessment includes persistent cervical vestibular symptoms, then your therapy should focus on those factors, as we've already discussed and have shown you on those previous slides. Other changes to activities of daily life may include moving the person's seat in class to limit head motion, not letting them operate motor vehicles, don't drive, and gradual exposure to more busy environments. If the multimodal clinical assessment instead indicates that the persistent cognitive or lack of energy, fatigue-related symptoms, then we may need to have them focus on standardizing their daily routine. One of my colleagues refers to this as grandma or toddler therapy, as those particular populations generally have set schedules. That tends to be beneficial for people that are having fatigue and cognitive-related issues. Academic adjustments in the short term may be adequate, but after 4 weeks, arranging for speech therapy or neuropsychology assessment may be beneficial. If your multimodal clinical assessment is indicating persistent headache or migraine symptoms, we generally want to treat those migraines as the same as we would without a history of concussion. Keep in mind the family history puts them at a higher risk. And ask about that to kind of determine where you feel like this may be going. If they're having daily symptoms, we may want to consider prophylactic treatment, sometimes with over-the-counter supplements like magnesium or riboflavin, which are commonly used, or with actual medications that are being used on a daily basis for the treatment of migraines. And thus, access to a neurologist with experience in post-traumatic headaches and migraines is extremely helpful in those cases. If your multimodal clinical assessment includes mood symptoms as the predominant avenue, we need to ensure there's adequate support system available for these patients. The patient should be able to share their progress and their difficulties with parents, the school nurse, a counselor, the physician, or an athletic trainer. And it may be necessary to develop an emotional support plan for the students and identify an adult with whom he or she can talk to if they're feeling overwhelmed. Referral to psychology or psychiatry may be necessary to encourage cognitive behavioral therapy or medication usage for underlying mood disorders that have, again, been magnified in the post-concussive environment. If the mood is impacting learning or attention, continued communication with the school is valuable to make sure that the academics are not also falling behind and leading to additional reactive depression or anxiety type symptoms. The next point of interest is potential retirement. This was an entirely new segment addressed in the new consensus statement. Unfortunately, definitive criteria remains nebulous without definitive factors that should directly result in your athlete retiring from contact or collision sports. The expert panel did acknowledge the importance of having a multidisciplinary team available to provide multiple points of view. This is ultimately a highly personal decision-making process and requires open communication between the patient and the family. Some factors I personally consider under these situations is not necessarily the total number of concussions that relate to any kind of retirement from sport, but we do pay attention to the overall number and how many of them have occurred most recently. We also pay attention if there's longer recovery times. Maybe they did get over their symptoms the first 3 or 4 concussions within 1 or 2 weeks, and they had normal recoveries. Maybe on concussions 5 and 6, they're going over several months in terms of return. That's concerning. If there's shorter intervals between the concussions, they have multiple in the same season. If there's less traumatic impact or force that's needed to actually cause a concussion, it's one thing if you're getting slammed by a linebacker and having concussion symptoms. It's another thing entirely if you're lightly tapping your head on a door frame and having symptoms that are lingering. And also if they haven't returned to their normal or their baseline before they went back and took another hit. Ultimately, fully removing an enjoyable sports activity can be detrimental as well. So the risks and benefits of sport need to be balanced. And hopefully you can find something that isn't contact or collision related for those that are getting into that danger zone in terms of their recovery. This does not have to be an all or nothing decision. After sustaining multiple concussions in a single sports season, having an adolescent take 3 to 6 months off from contact sports while monitoring their symptoms is probably beneficial. And it will help the athlete and family gain perspective and make a better informed decision overall for them. We want kids to be active. We do not want to exclude or disqualify from athletics or even keep them out for longer than necessary unless they're having more concerning findings. This is a slide from the Aspen Institute's initiative Project Play, and I think it's a great reminder of why I do what I do and why we want kids to be active, maybe not involved in sports, but at least get themselves moving. Physically active children in early childhood, as you can see on the bottom gray zone and then following this around through the blue ribbons section are within the pediatric time frame 90% less likely to be obese. They have higher test scores and perform better academically, less chance of smoking, drug use, teen pregnancy, or risky sex activities. They're more likely to go to college and the midterm in early adulthood, higher annual learnings, overall lower health costs, more productive at work. Basically, there's no downsides here overall. And then there's the feedback portion shown in the yellow ribbon section, where those who have active kids tend to have more active kids themselves once they become parents. And so it's a feedback loop that we hope to influence overall for the betterment of society. I've talked at length about the updated recommendations tools and the importance of customizing treatment to the patients and their symptoms we find in front of us, but I think it's valuable to circle back around and view what a standard roadmap for recovery after sport-related concussion may look like within the most up-to-date standard of care. So first, removal from activity or sport when TBI is suspected, using the visual indications of what you see in front of you, red flag findings, as well as the clinical diagnostic standards, and not letting them back into play before they get reassessed. After the first several days after the diagnosis of recovery, you allow for rest, given a break from screen use over the first 72 hours, and encourage light activity to their tolerance. If headaches, neck pain, or dizziness are predominating, then we want to start that early vestibular ocular or cervical PT at about the 10-day course. We want to really push that early cardiovascular activity and encourage them to get back to their normal. That includes sleep, really paying attention to sleep hygiene, getting back on a good nutritional meal schedule, and getting them back into school with or without adjustments where needed. Seeing a skilled practitioner is going to be important in the form of their PCP, an athletic trainer, or a concussion specialist to kind of quarterback and advise them on the correct treatments that are associated with improved outcomes. Finally, if the symptoms are persisting beyond 4 weeks, a multimodal assessment seen with the SCOT would be indicated along with specialized treatment based on what symptoms are predominant. In summary, today we discussed the origins of the Amsterdam Consensus Statement on Sports-Related Concussion Activity that was released in June of this year, as well as there are several new key points and tools, specifically early aerobic exercise as treatment, sport-specific concussion prevention strategies, the updated return to learn and return to sport strategies, the importance of PT for cervical vestibular rehabilitation if symptoms are persisting beyond 10 days, and strategy for persistent symptoms if that duration gets prolonged beyond 4 weeks. We've reviewed the updated concussion assessment tools that are now version 6.0 at this point here. Once again, I draw your attention to the free resource within the British Journal of Sports Medicine that includes the consensus statement, the various supporting documentation, and the various concussion assessment tools in PDF format. I have tons and tons of resources and other resources available if you want to look into things further. But I really appreciate your guys' time here today and let me speak at this event. Happy to take questions.
Thank you so much for that incredible overview of new concussion guidelines. As somebody who doesn't do a lot of this, I had absolutely no idea that so much had changed, in particular with the early return to activity. So that's a really important thing to know. Could you share a little bit about what resources are available for pediatricians, sort of when they've done some screening and are concerned? What is the time, like the wait time to get into clinic? Are there any outreach to neighbor islands? Is telemedicine an option? Can you give us a little bit of information about, sort of practically speaking, when the PCP needs some help, what should they do?
Right, so that's an outstanding question. My wife is a pediatrician, and it was the first thing she asked when I was going through this with her as well. So I think kind of drawing attention to that expected timeline of recovery and where maybe the person in front of you's recovery deviates from that. And so within the acute setting, if it sounds like a concussion has occurred, certainly the first and most important thing is to make sure that they aren't returning to an activity that could put their head further at risk, and letting them return to activity to their tolerance. You're trying to get them back into their life to what they're able to tolerate. After those first 72-hour window where you can kind of limit screen usage, make sure that they are resting adequately, see if they can start light cardio activity. You shouldn't feel scared to do those things as a primary care provider in that particular environment. If you're seeing them back and they're turning the corner with that might be all that is required. And so certainly at that point, I would hope that a lot of practitioners feel very comfortable taking that on. If you're blowing past 10 days of recovery and things are either worsening or they haven't been able to get back into school because of their perceived symptom load, even with adjustments that you're giving to them, that's where thinking about a referral is a good idea. And these are actually the ones that we try to bring in as soon as possible. I should explain that the the multidisciplinary concussion clinic is a great resource. I love having a speech therapist, a vestibular therapist skilled over my shoulder, and we can do all the testing on point. But that's not always necessary in a lot of cases. And if we hear that someone is having considerable symptoms, even 2 weeks out from injury, and they're having trouble getting back to school, we'll usually call an audible and just try to see them in regular clinics sooner than the next scheduled concussion clinic in order to get them in. We can see folks who from neighbor islands over telehealth. Some of the tools that we utilize, including the vestibular ocular assessments, are going to be a little limited when we're doing it over a screen, but they can be replicated. And we do have a version of telehealth that we run. So we do see patients from neighbor islands via telehealth at times to make that happen. Again, generally, if we hear if we get a referral from a PCP that says, hey, they're not turning the corner within a couple of weeks here, in fact, they're getting worse, we're having trouble getting back into school, we try to get those moving sooner rather than later, because again, kind of delaying that return to normal and getting them the space they need to get there is going to be important. When things are a little bit more chronic, it's time to maybe set our feet, or if there's been multiple concussions in their history, having the concussion clinic as an assessment area is probably more applicable and useful in those cases. I hope that provides a little clarity.
Thank you. So would it be fair to say that under those circumstances, when a PCP feels that their recovery is not as expected and they would like to get them into the multidisciplinary concussion clinic or have them seen by you folks sooner, within a week, is a reasonable expectation?
We always try to get them in as soon as possible. Our current workflow, when we hear about a case where the people aren't turning the corner, we actually have athletic trainers that look through all these charts, occasionally review it with us if there's any concern or complaint on it, and almost always we'll have slots. It depends on the time of year. Football season's always a little tricky, but yes, we try to get people in as soon as possible if we feel like they're on the roads to a prolonged recovery. On the other side of things, if things have truly been chronic, we try to line them up with the longer blocked out time in concussion clinic where we have multiple specialists available. So yes, just to kind of clarify what we do with those, we do have people that snipe the charts and that try to bring people in a timely fashion that's most applicable and personalized to their case.
Great, thank you. That's really, really helpful and practical information. There are a couple of questions in the chat as well. The first one is, would you recommend a 10-word recall as a routine for pre-sport physicals in order to have a baseline?
That's an outstanding question. According to the literature and the research that's here, yes, absolutely. That would be fabulous. The reality is that's a little tricky to pull off. Folks who have an athletic trainer already in their high schools, and in Hawaii, we're blessed that all the DOE the vast majority of DOE schools have at least one athletic trainer available, and most of the private schools as well. They're already doing preseason testing with usually the computerized testing with either impact or sway testing. So to have an additional baseline with that would be considerably helpful, so you have something to compare it to, and that has been shown to at least have that baseline can be very helpful. Yes.
Thank you. And then the second question, and I don't know if you know the answer to this, is at what point will dental start covering mouth guards for children and adults for preventative care? It sounds like it would be a good investment on their part.
I don't know, and I would love that. What a fabulous question. Yes, especially now that we've got evidence to back up the use of mouth guards, at least within hockey, but it can be extrapolated to other sports. I would love to see that occur. I don't have a great time frame on that, but I will happily sign on to whatever public initiative we want to push through.
Great, thank you. Folks, we've got about 2 more minutes. If anyone has any other questions, please feel free to unmute yourself and ask. Oh goodness, we forgot about the poll. So maybe we better take our 2 minutes for the poll, but you can also throw your questions in the chat at the same time.
Apologies. Should I be running the poll here too?
No, I'll
Okay.
run it for a little bit, and then if the answers are pretty varied, maybe you could go over a couple of them.
Sure.
And see here.
Folks, are you seeing the poll? Because on my end, it says 0.
Oh, you're a co-host, Maya.
I know, but it says nobody's participating. Are you seeing answers coming in?
Oh yeah, no, not yet. I think they're taking a little bit of time.
Okay.
These are longer choices.
Sorry, my first time doing this.
No, it's good. It's just we waited to the end.
No worries.
Rihanna always can't see it. I don't know why. Oh, no questions.
Bummer.
I
Oh,
see
there's
someone
somebody.
answering.
Somebody
Yeah.
answered it.
We should close the poll there. 100% correct.
Huh.
Yeah, I think folks are having trouble with the poll because oh no, now more people
Well,
are doing
people
it. I
are
see.
answering. Yeah.
Okay, good.
It appears most people's test taking strategies are coming through in terms of picking the longest answer choice, always selecting all the above.
I don't know.
The only one I caught people on were the all of the following are true except. Oh man. Feel like a meanie.
Oh, yeah. Oh, yeah. We're at like 1/3. He'll
Okay,
probably
well,
go
maybe
over
for
the
those that-
question.
I was just going to say the same thing.
All
Can you
right.
go? Great, thanks.
Absolutely. Oops. I'm rolling through the slides over there. So from the top section, always true of physical activity after sustaining a concussion. The answer is early subthreshold physical activity and aerobic exercise, even while mildly symptomatic, is associated with improved recovery and is considered standard of care at this time. It looks like the majority of folks were jumping on that bandwagon. So good to see that one came across loud and clear. That was really the most important piece here. Which of the following was found to be significantly preventative regarding concussion in athletics? We talked about all of these in the prevention slide. All of them are present. Mouthguard use, limited contact practices, and neuromuscular warm-ups were all shown to be significantly protective against concussions. Number 3, which is true of returning to learning after a concussion? The answer is teachers should permit and encourage the recovering student to participate at the highest level they are capable, even while mildly symptomatic, with their adjustments as needed. And not all patients who have a concussion will require academic support. And then finally, it was the all are true except question, which is always the one that gets people. Cancer imaging. I gotta figure out which ones I put through here. Here we go. Decisions regarding retirement or discontinuation from contact or collisions at sports based on the lifetime concussions and specifically how many times the patient has been unconscious. That's not true. The decisions regarding retirement from contact and collision sports are highly individualized and don't have a specific number or evidence-based definitive pattern associated with them. All the rest of those findings, including the advanced neuroimaging, biomarkers, showing promise but are not intended for in clinical practice, that's true. Strong evidence exists regarding the benefits of physical activity, that is also true. And the cervical vestibular rehabilitation included for athletes with neck pain, headaches, and dizziness problems after 10 days is also true.
Fantastic. That was so educational and clear. So on behalf of all of us, there were several mahalos in the chat already. I'll say again, thank you very much for sharing your expertise and these new updates with us. It's a common problem and something that we all need to know about. So thank you. We would love to invite you back next year for something equally educational and interesting. And everybody have a wonderful day.
Thanks so much for having me.